So I'd like to introduce our speaker today, Dr. Elizabeth Dahl. Dr. Dahl attended medical school at the University of Louisville and then completed her pediatric neurology residency at the University of Utah in Salt Lake City. She returned home to Louisville in 2016 as a pediatric neurologist for Norton Children's Hospital and the University of Louisville. She also completed an acupuncture training at Harvard University in 2017 and has a weekly acupuncture clinic. Therefore, Dr. Dahl is able to bring a unique perspective, understanding, and potential treatment to patients with headaches and migraines. So that is what she will talk about to us today. So I'm going to turn it over to Dr. Dahl.
Okay, so yeah, I'm a general child neurologist, but I do kind of have a niche in headache medicine. I just received my board certification in headache medicine in addition to child neurology. So I do have an ongoing clinical drug trial with fremonizumab, which is one of the drugs that I'll be alluding to today, but there's no financial relationship with that. We'll discuss just some background on headache. Pediatric headache is one of the most common disorders in children and adolescents. We'll discuss primary versus secondary headache and kind of distinguishing one versus the other and some red flags to look for. We'll talk about migraine diagnosis and management, because really, a lot of what I see in clinic, I would say 90 to 95% of what I see in neurology clinic and headache clinic is migraine. So I really do want to focus primarily on migraine. And the American Academy of Neurology has actually come out with new guidelines for migraine for both prevention and acute treatment. And then at the end, we'll also talk about some new treatments that have come down the pipeline that are more of like designer drugs for migraine. Most of the treatments that we use in pediatric migraine are off-label, as is the case in pediatrics. A lot of these treatments haven't really been rigorously studied in children, but like with some of the newer treatments, we are starting to conduct trials in children. And then if we have time at the end, we'll kind of talk about a couple of cases. So just some background on headache disorders. Just in general, about worldwide, 3 billion people have a headache disorder. So that's a pretty large chunk of the worldwide population. Migraine is considered to be in the top 10 of disabling diseases by the World Health Organization. In pediatrics, the 1-year prevalence of headache is about 30 to 40%, so very, very common. And really in children, about 1 in 10 children have migraine. So it's it has a pretty significant impact on their lives, their ability to attend school, their social relationships. Headaches are the #1 reason for referral to child neurology. So we see it all the time. It's also in the top 10 for visits to a primary care provider and to urgent care or emergency department. Migraines are the most common headache disorder that we diagnose in neurology clinic. And again, as I mentioned earlier, migraines are associated with poor quality of life scores. And they've actually found that it's similar to arthritis and cancer. So it has a huge impact on kids' lives. So I'll spend a little bit of time talking about primary versus secondary headache. So when you think about a primary headache disorder, that's a type of disorder that doesn't really have any kind of underlying metabolic or structural cause. So it's not like a diagnosis that you make with a brain MRI picture. It's a clinical diagnosis. And however, with secondary headaches, if you don't take a detailed history, it can be hard to distinguish a primary headache from a secondary headache. So I'll kind of talk about some red flags to look for. And again, in general, headache disorders are clinical diagnoses that can be determined based on the history and neurological examination. So this is just kind of overview of how headaches are delineated. So when I first see a patient in clinic, the first thing I need to do is kind of figure out, are we dealing with more of a primary headache disorder or secondary headache disorder where there's some cause like a brain tumor, intracranial hypertension, hemorrhage, etc., versus the primary headache disorders, which are actually, they're not as many primary headache disorders, but they do, there are, migraine is so common that there are more primary headache disorders than secondary headache disorders. So again, number one, migraine, as far as what we see in clinic, but the most common type of headache is actually tension type headache, but it just doesn't really come to medical attention all that much just because they're not so debilitating. And then under primary headache disorders is cluster headache and the trigeminal autonomic cephalalgias. These are exceedingly rare in pediatrics. I can probably count on my hand the number of times that I've actually seen cluster headache or the other TACs. And then there are some other kind of less common primary headache disorders like primary stabbing headache. I actually saw a patient with that yesterday in clinic, but it's good to be aware of the other primary headache disorders. And again, there are way more secondary headache disorders than there are primary headache disorders. So if you go online, there is a organization, there's an International Headache Society, and they publish a manual. It's called the ICHD-3, and it's kind of like the DSM of headaches. So it's basically outlines all the different types of headache disorders that you can see, both primary and secondary. And just to be aware that there actually are over 200 different types of headache disorders. So there is more than just migraine. So this is a mnemonic that was developed several years ago by an adult neurologist, and it's called SNOOP4. So these are kind of red flags to be on the lookout for when you first evaluate a patient with migraine. So starting at the top, S stands for systemic symptoms. So if the patient has any kind of fever, weight loss, extensive vomiting, if they have, secondary risk factors like HIV, etc. Obviously, if they're having any kind of neurological symptoms or signs on examination, you would want to be thinking about a secondary headache diagnosis. This, onset is important in pediatric population, although we see it more in the adult population with what's called like a thunderclap headache, where you have, split second abrupt onset of headache. That's, concerning for conditions like subarachnoid hemorrhage. So if a patient says that their headache kind of reaches maximal intensity within a minute, that's concerning for a secondary type of headache disorder. So older patients, so this is not really relevant to pediatrics, but if they're older, like greater than the age of 60, and they start to complain of a new headache, that's a red flag, potentially. Now they keep adding P's. There's actually 10 P's now, but we're just going to focus on the 4 P's. So a pattern change. So if it's like you're seeing them the first time, their first headache, you want to be kind of on a lookout for any cause for that particular headache. Or if the headache, was kind of stable for a long time and now it's kind of different than it was before. Any kind of headache that's precipitated by Valsalva or bearing down, that can be a sign of increased pressure in the head. Any kind of positional change. So, if it's worse upright, that can be a sign of decreased pressure. Whereas if it's worse when they're laying down, that's a sign of increased pressure potentially. And pregnancy, which hopefully we don't see too much of in pediatrics. And then young age. So it's really, for pediatrics, it's we should probably call it Snoopy, because young age, so kids that are kind of less than 6 years of age, it's hard for kids at that age to express their symptoms, and kind of describe what they're feeling. So you do have to kind of have a little bit, your index of suspicion should be a little bit higher in those particular patients. And just for everybody's knowledge, the incidence of pediatric brain tumors is quite low. Although we do see it more, apparently Kentucky has one of the higher rates of pediatric brain tumors, but in general, the incidence of pediatric brain tumors is about 5.6 per 100,000. So it is exceedingly low. And, a lot of families, when they come in to see us in clinic, are concerned for brain tumor. But if the patient has a totally normal neurological examination, there's really no concerning features in the history, you can make a diagnosis of migraine and you don't need to get brain imaging, which I'll kind of talk about here in a minute. So if you're going to get any kind of imaging for headaches, in general, MRI is preferred. CT has a very limited role. If a patient is coming into the emergency department with like a thunderclap type headache, obviously you're going to want to get a head CT. CT really doesn't give you a lot of detailed information. It's not going to give you good detailed anatomy. So you're really looking for like fractures or bleeding on a CT scan, but otherwise it's pretty much not helpful at all for headaches. It's also interesting that 50% of head CTs are thought to be medically unnecessary, and we perform 80 million per year in the United States. And they believe that there's one case of cancer for every 1,000 people who are scanned. So we really ought not to be doing so many head CTs. So again, MRI is preferred, and MRI can give you a lot more detailed information as far as the anatomy. It can help with any kind of pressure changes, infection, or obviously ruling out a neoplasm. So in looking at studies of patients with brain tumors, headache as an only symptom of a brain tumor is exceedingly uncommon. And so the more time that passes, actually, the more comfortable I feel. I have patients that are like saying that they've been having migraines for 3 years and that's not normal. Well, actually, that makes me feel a little bit better that it's not a brain tumor because it's been going on for so long. So and this is a quote that I found in one of the papers written by an expert in headache medicine, Dr. Goadsby. He said, if the neurological examination is normal, then brain scanning is next to useless to plan management. So reasons for referral to child neurology. Obviously, we welcome any kind of referrals to child neurology for headaches or other conditions, but particularly like if a patient's having intractable migraine, despite treatments that you might have started, if it's more of a kind of, if they're having headaches to the extent where they need some kind of preventative therapy. Comorbid conditions or complicated syndromes. So if they're having, weird types of auras, like if they're having a hemiplegic migraine, cranial neuralgias, which are not that common in children. However, we do see pseudotumor cerebri very frequently. I did my training in Utah, and I didn't really see a whole lot of pseudotumor there, but when I came back to Kentucky, I feel like we see it all the time, and I think it has to do with the obesity epidemic. Concussion, we're happy to see patients for concussion. If any patient has any abnormal brain imaging, if you want a second opinion, and as I mentioned earlier, if they have a headache that's kind of outside of typical migraine, then we're happy to see them in child neurology. Okay, so as far as diagnosis and management, I have students rotating through our clinic all the time, and I tell them that, we have this ICHD-3 manual. It's like, several hundred pages. You're not going to be able to memorize the entire manual, but, you really ought to memorize the diagnostic criteria for migraine, because you see it so much that it's important to have kind of a working knowledge of what constitutes a migraine. So according to the ICHD-3, which was kind of republished in 2018, you have to have at least 5 attacks for migraine without aura. So in adults, headaches can last from 4 to 72 hours, but in pediatrics, it actually can be shorter than that, anywhere from 2 to 72 hours. So in kids, it tends to be a little bit shorter. Then there are 4 pain criteria. So unilateral, I kind of put a star next to that because it's more commonly bilateral in children. They'll describe a pulsating or throbbing quality. Migraines, by definition, have to be moderate to severe pain intensity. And it's aggravated by activity. So they want to lay down in a dark room and rest. So they have to have 2 of the 4 of those pain criteria. And then you have to have at least 1 of the associated criteria, which is nausea and or vomiting, and photophobia or phonophobia. And then just briefly kind of touching on migraine with aura. So in adults, migraine with aura is about 25% of patients. It's less in children. You don't have to have as many attacks to call it migraine with aura, so 2 attacks. And there are different types of auras. The most common being visual aura and like the scintillating scotoma, where you have changes in your visual fields. But you can also have sensory disturbances, so like numbness and tingling. You can have changes in speech or language. So you can have like aphasia or dysphagia, so difficulty finding words. You can have motor symptoms. So that's kind of like the hemiplegic migraine, where you have potentially weakness on one side, and that is scary because it looks like a stroke. And the first time a patient comes in with that, you do have to do the full kind of stroke evaluation. Kind of the same for the speech and language, as well as the brainstem and retinal migraine. So brainstem aura, which used to be called basilar migraine, that's where you have symptoms that are kind of referable to the brainstem. So where patients have like altered mental status, and I've seen that on a couple of occasions, and those patients oftentimes land in the ICU. I had one patient that was actually intubated, but ultimately we decided that, at the end of the day, after everything came back normal, we kind of chalked it up to a brainstem migraine aura. And then retinal migraine. So typically a migraine visual aura is bilateral. So you have disturbances in kind of both eyes, whereas with retinal migraine is specific to like a monocular visual disturbance. So that's what's called a retinal migraine. Okay. Oh, and then just a point on chronic migraine. So we use that term kind of colloquially to mean like, okay, they've been having a migraine for a long time, but technically to qualify for a chronic migraine diagnosis, you actually have to reach a pretty high bar. So you have to have at least 3 months of headaches, and you have to have 15 days of headaches. So that's a lot of headaches. It's half of the days per month that you're having headaches, and at least 8 of those headache days have to be migraine. So we don't actually see chronic migraine all that much in pediatrics. I think it's about 2% of migraines in pediatric population. So this is some drawings that were done by children who have migraines, and In the top left is a 4-year-old patient who is describing her experience with her migraine, and she's showing the sunshine. So she's kind of is able to express her symptoms through a drawing and showing her photophobia. So it can be helpful for patients to kind of draw what they're experiencing. The other the other two that they're describing kind of the symptoms that they're experiencing. And in the bottom right-hand corner is a patient describing some phonophobia. So like they feel like, you know, the drums are playing in their head. So our understanding of migraine pathophysiology has changed pretty significantly over the last several years. We know that it is a condition with disordered sensory processing, so it has contributions from both the central and peripheral nervous system. And there's actually 5 phases of migraine. It's not just headache, so we obviously think of headache pain. But if you really take a detailed history and talk to patients, you know, especially as they get older and are kind of able to discern a little bit more, but there is oftentimes kind of a prodromal or premonitory phase. So they may have like yawning, fatigue, food cravings, etc. Then you have aura. So not everybody has aura, but aura is thought to be mediated by this, you know, cortical spreading depression. And then the headache pain, obviously. There's a post-drome phase. So sometimes patients, after they have had a headache, might describe kind of a lit down phase or kind of a hangover effect. And then there's this interictal phase. So that's the in-between phase. They're not having any pain. And the reason that that's important is that, you know, from a research standpoint, is that, you know, what's different about the interictal phase, and trying to kind of capitalize on that so that the patient doesn't kind of progress into a migraine. So overall, you know, it's pretty complicated how it all works, but we know that the trigeminal-vascular pathway is the most important part of kind of the driver for migraine. And the early vascular theory has been debunked. So we used to think that the migraine aura was mediated by vasoconstriction, and the migraine pain itself was vasodilation, because, you know, triptans actually cause vasoconstriction. So they're thinking, okay, maybe triptans work by causing vasoconstriction, and migraine pain is vasodilation. But we're actually now finding that triptans work a little bit differently than just causing changes in blood vessel constriction. And I'll kind of touch on that in just a minute. And obviously, kind of just looking at this drawing on the right, there's a lot of pathways in the brain, like the thalamus and the hypothalamus, that are important with migraine. So this is kind of an interesting diagram. You know, when you think back to statistics, you think about incidence and prevalence. So incidence is kind of the number of new cases in any given time. And prevalence is like the frequency at a given time. So when you look at this, so the open circles are boys and the closed circles are girls. So if you look, you'll actually see that males actually start to have migraines earlier in life. So kind of the peak incidence of migraine with aura in boys is around 5 or 6, and without aura is like 10 or 11. And then girls start to have migraines a little bit later in life, typically, but once they start having migraines kind of in their preteen or teen years, they start to outpace boys pretty significantly. So it's pretty common for me to see like younger boys in my clinic and then teenage girls. So, the number one patient in my clinic is probably a teenage girl, but I do see a number of younger boys as well. And then if you look at the prevalence, so kind of the frequency at a given time, migraines are 3 times as common in females as in males. So kind of in adults, and especially in females, about 1 in 5 females has migraine. So I kind of appropriated this analogy from one of, there's a child neurologist at Johns Hopkins who when he talks to his children or his patients about migraine, he talks about building a house. So, even young children are kind of know how a house is built. So, he says, how, when you start to build a house, what do you start with? And they'll be able to say, okay, you start with the foundation. You don't start with the roof, because then the house will just collapse. So you need a foundation. So really the foundation of managing migraine is the lifestyle factors. So if a patient is not taking good care of themselves, they're not getting good sleep, not drinking enough water, have a lot of stress in their life, etc., that is really going to make it hard for you to manage their migraines despite, medications, etc. And then, you build on top of that foundation with, preventative medicines potentially, and acute treatments. So I call it the big 5. So I try to address these at every single visit with every single patient that I see for migraine. It's actually in my template. So hydration and nutrition and caffeine kind of I lump together. So, an adolescent really ought to be drinking at least like 60 ounces of water per day, eating regular meals throughout the day. So not skipping meals, not skipping breakfast or lunch, and trying to limit caffeine intake. And also eating healthy, kind of varied diet. Sleep. So sleep is a big thing. Unfortunately, a lot of our teenagers are really kind of not doing a good job there. And some of that has to do with, school schedules not being really conducive to a teenager's biorhythms. Stress. So stress is the number one trigger for migraines. And about 50 or 60% of patients have 50 or 60% of patients with migraine have comorbid anxiety or depression. So that's actually quite common. And so we spend a lot of time addressing that in clinic. I also recommend some regular exercise every day, 30 minutes of cardiovascular activity to get their heart rate up. And then limiting screen time as much as possible. I know that's kind of a losing battle, but, trying to at least cut off screen time before bed, an hour or 2 before bed, because that blue light can kind of tell the brain to stay awake. So here's kind of like our standard approach to migraine prevention. There's a lot of kind of conventional treatments, and then I'll also talk about some other treatments that I use fairly commonly. So one of my colleagues, he actually calls them the anti-meds. So there's 3 of those. So the antidepressants, the antihypertensives, and the anti-seizure medicine. So the antidepressants, we have the tricyclics, the amitriptyline, nortriptyline. Amitriptyline tends to be a little bit more sedating, so you can sometimes use that to your advantage if a patient's having a hard time sleeping. And then the SNRIs, so venlafaxine and duloxetine, I use on occasion. The SSRIs have not been shown to be particularly effective for migraine, even though they can help with, their comorbid anxiety or depression. It may not help with their headache. Then we have the antihypertensive, so the beta blockers, calcium channel blockers. I will say that I don't tend to use a lot of these in kids just because most kids are pretty healthy and are not hypertensive. And then if you put them on a beta blocker, they kind of feel crummy. But I do use these on occasion. And then we have the anti-seizure medicine. So valproate, which I very rarely use just because of the side effect profile and the monitoring that you need to do with valproate. I use mostly topiramate, which has probably the best evidence in children, in addition to amitriptyline. And then zonisamide, which is a cousin of topiramate, I use sometimes as well. And then you have the nutraceuticals. So these are coenzyme Q10, magnesium oxide, and riboflavin. So CoQ10 and riboflavin are kind of part of the mitochondria function and like the electron transport chain. So it has to do with energy metabolism. We don't know, really why they work for migraine, but there is some good literature to suggest that they can be helpful. Magnesium oxide is a NMDA receptor antagonist. So you think of NMDA and glutamate as being an excitatory neurotransmitter. Magnesium blocks that excitation, so it can kind of calm down the brain. So that's kind of how those work. And so really, when I see a kid in clinic, oftentimes I'll start with the vitamins first or the nutraceuticals, because you really can't lose with that. I mean, it may not help them, but it's a good place to start, and it doesn't have a lot of side effects. So I generally will start with the nutraceuticals unless the patient's really, if they're having really debilitating migraines, I may use different treatments there. And then I'm gonna talk about on the right, I use antihistamines like cyproheptadine, typically in younger children, like less than 10, but once they reach double digits, I tend to avoid using those just because, cyproheptadine can cause weight gain, and you have to keep increasing the dose, and there's really not a lot of evidence for it. But I will use cyproheptadine in younger children. Botulinum toxin. So we are actually starting to do Botox in pediatrics. So we started to do that. Dr. Plato's group does that as well, but we have, in our group, we've started to do Botox. There are different types of nerve injections. So occipital nerve blocks, etc. So if they have like specific kind of occipital nerve pain, you can do an injection there. Acupuncture, which I do, and actually Dr. McDonald kind of paved the way for that when he first started several years ago. There's the newer class of CGRP inhibitors or antagonists that I'll kind of talk about a little bit at the end. There are other kind of neuromodulatory devices like the trigeminal nerve stimulator. There's the non-invasive vagus nerve stimulator. You have transcranial magnetic stimulation, and then there's a acute migraine device called the REN, or the remote electrical neuromodulation. And I'm starting to use these more frequently, these devices for migraine. The only issue with them is that there's typically not a lot of insurance coverage for them. So it's generally kind of like an out-of-pocket expense and can be prohibitively expensive for some families. But like yesterday, I saw a patient in clinic, and the family was kind of opposed to trying a lot of pharmacologic treatments, but she was having chronic migraine. So I had recommended the Cephaly device, or the external trigeminal nerve stimulator, as an alternative choice. But that's something that I'm starting to do more and more. And generally speaking, there's no real like cutoff for like when do you start migraine preventative. It depends on how kind of debilitated the patient is, kind of patient choice. But generally speaking, if they're having like 4 migraines or more per month, so like 1 headache per week, I generally tend to offer migraine prevention. There were actually, as I mentioned earlier, there were some new guidelines that were published recently, like in 2018, I believe. American Academy of Neurology and American Headache Society. Actually, Dr. Michael Sowell, who's one of my colleagues, he was on this paper. And it was a group of headache experts who kind of looked at the existing evidence for acute migraine treatment and preventative migraine treatment. And for headache prevention, really there were no big updates, but they did say that amitriptyline and topiramate have the best evidence in children. As is the case in pediatrics, we need more randomized control studies. But they do mention that cognitive behavioral therapy should be considered. So that probably has the best evidence of, as far as types of therapies or psychology practices, cognitive behavioral therapy is probably the best. So many of you may be familiar with the CHAMP trial. We were actually one of the centers that was involved in this particular trial. And it was looking at, it was like over 300 children that were aged 8 to 17. And this was kind of all over the United States at different centers. And they were looking at treatment of patients with episodic or chronic migraine. And so they put the patients on amitriptyline, topiramate, or placebo. And they found that everything worked. And in fact, the placebo was equally effective as amitriptyline or topiramate. So all of the patients had like a 50% reduction in their headache frequency and disability. And so, I guess I'm kind of reticent to share this study with my patients because sometimes, it's like they feel like, okay, well, if the placebo is just effective as the medication treatment, are you just saying that this is all in my head? No, I mean, migraine truly is a headache disorder, but it does go to show you that, just try something, try some treatment. Hopefully that will help the patient. That was kind of my take home point from this particular study. And that's why I generally do tend to start with the vitamins as well, just because it's, worth seeing if that will help with their migraines. So as far as acute treatments, we have, actually there's 7 commercially available triptans, and then there's this like sumatriptan naproxen combo that's called Trexamet. And the ones that are underlined are FDA approved in children. The only one that's FDA approved in the 6 to 12 age group is the rizatriptan. So I generally tend to use more of the rizatriptan than the others, but I also use the others fairly frequently. And in fact, they just published, in addition to the preventative treatment guidelines, they just published, acute treatment guidelines. So really, the first line for all patients should be ibuprofen. And a lot of people that take ibuprofen, that will abort their migraine without needing a triptan potentially. So, when I see patients in clinic, oftentimes they have tried ibuprofen and they say it doesn't work. So I do have to offer them something else. You'll also note that there is not acetaminophen mentioned on here. So ibuprofen does tend to be more effective than acetaminophen. So a second line treatment, kind of looking at all the data, they found that the kind of oral sumatriptan naproxen combo and the Zomig or zolmitriptan nasal spray is probably the most effective. But they also kind of mention the rizatriptan and almotriptan as well. They also mention that combining an NSAID plus a triptan together can kind of have a synergistic effect. So that's something that I do pretty frequently. And then if the patient's having a lot of nausea, vomiting, then offer an anti-nausea or anti-emetic medicine. I tend to use more promethazine or Phenergan or Zofran. But if you look at if you ever have gotten Zofran or ondansetron, it actually says on the label that it may cause headaches. So it's kind of a little questionable. Just to briefly mention tension type headache, I talked about this earlier. It actually is the most common type of headache disorder. It has a very high lifetime prevalence. Tends to be kind of that bilateral band-like pain, but it's not aggravated by physical activity, no nausea, vomiting. They may have photophobia or phonophobia, but not both. And it's called tension headache. So it can be worsened by tension or stress. But a lot of times these are, so mild that they don't come to medical attention necessarily. So as far as new treatments, this is kind of an exciting time to be in headache medicine because there have been a lot of new treatments coming down the pipeline recently. And this was an article that was published a couple years ago about migraine headache, about some of these new treatments. So CGRP, so that stands for calcitonin gene-related peptide. It is the most abundant neuropeptide in the trigeminal nerve. So it's a protein that's released kind of in that pain cascade when someone has a migraine. And so these newer treatments are designer drugs. They're essentially targeting CGRP. So there's a couple of different types of treatments. We have kind of in the orange box, we have the antibody mediated treatments. So the monoclonal antibodies, and those either block the ligand or molecule itself, like on the right, or they can block the receptor. And then you have the smaller molecules that are called the GPANTs that are receptor mediated. And, like I said, I'm involved in the clinical drug trial with one of these. And, they're not FDA approved in less than 18. So it can be quite challenging to prescribe these in kids just because insurance companies are a little bit hesitant to use these in the pediatric population, but we are starting to use these more frequently. And especially if patients have tried everything and failed, I can sometimes make an argument for getting a CGRP antagonist. They are relatively free of side effects. Now that's kind of iffy because these have only been out for a few years. So we still haven't learned the full extent of potential side effects, but relatively free of side effects. Constipation is one that's kind of commonly listed. It doesn't have so with the monoclonal antibody treatments, it doesn't have a target in the immune system. So they're not going to cause systemic immunosuppression. There is some concern that CGRP blocking can affect bone growth. So I wouldn't use these in kids that have growth issues until we really know more about it. CGRP we know that it plays a role in wound healing. So what happens when we block it, still kind of yet to be determined. This was a paper that was published a few years ago that basically advocated for use of, especially with the monoclonal antibodies, in patients that have really tried everything and have failed. So just quickly, I want to leave a little bit of time for questions, but I'll talk about a case. So here's, 12-year-old boy has had a 3-year history of recurrent headache. Over the past 3 months, they're happening 1 per week. Headache pain is bilateral, so in kids tends to be more bilateral. And can be holocephalic as well. Throbbing, pulsatile, each attack about 5 to 6 hours. Photophobia, phonophobia. Half the time he has nausea. He can lose vision in the right eye. Kind of has this kind of black spot that expands, involves his entire visual field. The vision symptoms last 7 to 15 minutes, usually prior to the head pain, and then it kind of tends to dissipate once the head pain starts. So interestingly, further history reveals recurrent abdominal pain starting around age 6, and then mother had a history of migraine without aura. So is this a primary headache disorder? Yes, this is migraine with aura. It's not chronic because it's only happening 4 times a week. So I would call this an episodic migraine with aura. And this patient, I don't think that you're really obligated to order brain imaging because he has like a normal exam. He kind of fits criteria for migraine with aura. There's not really any major red flags. Since he's having 1 migraine per week, I would probably want to start him on a preventative treatment. You could start kind of cautiously with, one of the headache vitamins, but you could also use like topiramate or amitriptyline. And a lot of times, I'll pick one of these preventatives based on the profile of the patient. So if I have like a really skinny patient with depression, I might like to use amitriptyline, or if I have a patient that's really overweight, I might choose topiramate. So acetaminophen is ineffective. What should they try next? So they should do kind of an adequate dose of ibuprofen, and I do kind of probe patients to tell me kind of like how much are they actually taking. So they should be taking an adequate dose of ibuprofen. And then if the ibuprofen doesn't work, then we can try a triptan, and we can even combine a triptan with an NSAID. So in conclusion, pediatric headache is a common disorder in childhood, adolescence. Most of the headaches that we see are primary headache disorders, but it also is important to exclude secondary headaches. And I will say that like in kids, I tend to be a little bit more risk averse, and if like there's a lot of family parental anxiety, I may be a little bit more inclined to get brain imaging. But in most cases, you really don't have to get brain imaging unless there are features that suggest that there's a secondary headache type. And then we kind of discussed some updated guidelines on acute and preventative treatment. So I'm happy to take any questions now.
Thanks, Dr. Dahl. Did I miss it? But did you say how the triptans work with trigeminal?
Oh, sorry. Yeah. So we used to think that triptans worked because of the vasoconstriction, but we now know that actually the triptans work because they block CGRP. So it's kind of a new finding. So really it comes back to CGRP.
Interesting. Okay. And that's interesting too, the trigeminal pathophys, because that's where the ear points on acupuncture are that kind of relieve the headache too.
Yeah.
Okay. So is the question, is there a change of treatment in aura without migraine to follow? Migraine without aura to follow.
Okay. So repeat that question.
Is there a change in treatment of migraines without auras to follow? Is that coming up, or was there a change?
I don't know if I understand what the question is.
Pause on that question. Let me try another one. Is there a specific migraine medication recommended for migraines with auras?
So really, it's the same as you would use for migraine without aura. In patients that have migraine with aura and girls who are of reproductive age and are, potentially considering birth control, you want to be a little bit wary about prescribing triptans. However, kind of because there's a concern that, migraine aura can kind of heighten your risk of stroke. But we've actually come to find that, sorry, did I say triptans or OCPs? You don't want to, we've been told not to prescribe OCPs in patients that have migraine with aura, but that's kind of outdated because the newer formulations of OCP have like lower estrogen content. And so if you have a patient that doesn't have a lot of like stroke risk factors, you can really, I think it's okay to prescribe birth control. But just kind of be cautionary about that.
Is there a relationship between migraine and Tourette's?
It's a good question. I don't know if I know the answer to that. Obviously, like in Tourette's, there's typically kind of a triad of like OCD, anxiety, ADHD potentially. And so that, we see those conditions more commonly in patients that also have migraines. So, I would have to look that up, but I wouldn't be surprised if the incidence of migraines is higher in that population as well.
Okay. And then with the transcranial magnetic therapy, do you guys have a specific company you use, or?
We actually are kind of like, we have been in talks to get a transcranial magnetic stimulator because they're, they purchased it for epilepsy, actually, for, epilepsy surgery management. But we were going to actually use that for migraines, but we don't have that yet.
And would you just do it in the office? Yeah.
Wherever, yeah, I think, they would have the machine
Okay.
at the office.
I guess I had previously rented one from it's a company from eNeura, ENEURA, and it's a
Oh yeah,
kind of a pulse, one.
okay. Oh, gotcha. No, you're right. So there's actually like there is that device too, which is like a handheld device. And that is you can rent it, I believe. Yeah. I don't know if it's readily available, but it is something that can potentially be used.
I can't remember. I think it runs about 100 to 200 a month.
Yeah.
I think something like that. You use it twice a day.
Yeah.
And you had mentioned something about Fioricet. What was that about?
Oh, did I say Fioricet? I don't know if I talked about that, but that is an interesting question because it's really not recommended in children. So I don't prescribe it because it has butalbital in it. It's a barbiturate, and so it's sedating, and there's really not a lot of evidence for efficacy in children.
Okay. And there are patients out there that have auras without migraines.
Mm-hmm.
And so do you treat those patients?
It's tricky because really there's not a lot of evidence that triptans don't really treat the aura. So a triptan treats the headache pain. So if you give a triptan for an aura, it's not necessarily going to abort the aura. So those are tough patients, but yeah, you can have isolated migraine aura, without headache pain. Usually they'll have kind of both types of headaches. If you have a prolonged aura, So an aura that's going on for hours and hours, that is concerning. And those patients I will generally like hospitalize because, there is kind of a concern that it may kind of progress to like a stroke, because there is something called migrainous infarction that can happen, but that's like exceedingly rare. In the case study that I mentioned earlier, that patient had kind of abdominal pain without clear cause. And so kind of in retrospect, that would probably have been diagnosed as an abdominal migraine. But that can also be a challenging diagnosis to make, just because, again, it's kind of like a diagnosis of exclusion.
Yeah. And still abdominal migraines kind of go into when they get older, they get regular migraines.
Morph into migraines. Yeah. So we know that like motion sickness, colic, there's some paroxysmal disorders in childhood, like paroxysmal torticollis and some other, paroxysmal vertigo. All of those things can kind of morph into migraines later in life.
All right. All right, great. That's all our questions. Thank you very much. Thanks everyone for joining us today.